Do you need a microphone?
All right, we are ready to call the January 19th Board of Health meeting to order. First order of business is election of officers. Do I have a nomination for president? Yes.
On behalf of a very grateful board and in recognition of the excellent work that both Heidi by both our president and board vice president have done in the past 4 years, I'd like to renominate both of them.
All right, got a nomination for both. Are there any other nominations? Do I have a second?
Second.
All in favor?
Aye.
I think it's unanimous. I turn the meeting over to you, Mr. President.
Well, thank you, Mr. Levin. Is my phone on or my microphone on? Awesome. So why don't we do roll call?
Do we offer congratulations or sympathies? What are you asking?
Congratulations.
Oh,
for-
congrats.
for that.
Congratulations,
Michelle.
Michelle did.
Marcel, do I need to do a formal roll call?
I think we're all in person.
Okay, we're all here. So moving on to item number 2, adoption of the agenda. It's recommended that the Board of Health members adopt the agenda for the January 19th, 2022. May I have a motion?
So moved.
Second? Any discussion? All those in favor?
Aye.
Aye.
The ayes have it. The adoption of the agenda is approved. Number 3 is approval of the minutes. It's recommended that the Board of Health members approve the minutes of December 15th, 2021. Do I have a motion?
So moved.
A second?
Second.
Any discussion or corrections to the minutes? Not hearing any, we'll go to a vote. All those in favor?
Aye.
Aye.
All those opposed? We've approved the minutes. For the board president announcements, I'm happy that Jason and I are continuing in the role of president and vice president and are looking forward to this coming year, and Happy New Year, everybody. Moving on to the health officer's presentation and report, I'm going to turn it over to Dr. Einters.
Thank you, Heidi. You all should have received the report. And as usual, I will not go through it page by page, but I would like to point out a couple of highlights, starting with one item that's not in your packet, and that's to just let you all know that we have moved forward with the leadership development meeting, had our first session yesterday. This is with a group out of New York. And former colleagues of Mark Fox and myself, or one of them was a former colleague of Mark Fox and myself. And that went very well. Kudos to our HEED team and HEED leadership who pushed for this sort of leadership development. Went very well yesterday. It's very well received by all of our directors and unit directors, and a smattering of others had a chance to participate. There'll be a couple of more sessions, both online and in person. And but went very well. We were pleased with that. Second, again, just pointing out salient portions of this report. You'll note in the food services report that the online permitting, in fact, is ongoing. You will recall in past years, folks had to come into the county city building and up to the department to get their permits, and all this is now online. And Carolyn, who I think is on, yep, she's there, says that it's all going quite well. So we're pleased with that. They still need to have the permit itself mailed to them, but they at least no longer, that is, the restaurant owners no longer have to come in person to get it. So we moved into the 21st century. So hallelujah for that. No, well, we've got, sir.
Will that online permitting also include for, pop-up restaurants and fairs during the summer? Will that all be online or just the permanent food establishments?
It's a good question. I believe, Carolyn, can you help me out if you heard that question?
Everything is now online, so temporaries can get their permits online, pop-ups. Yeah, we have that availability for all permits and establishments.
Is there a deadline? Like how soon before the event do they have to have that done if they're going to be a one-time deal during the spring and summer?
The permits are to be processed no later than 7 days before the event. That hasn't changed. That's always been. So
Thank you.
you're welcome.
The one other piece of the report that I'll bring your attention to is the budget, the financial report that Amy Rupi puts together. And she just gave her a report a couple of months ago. And so I won't go through this in any detail whatsoever. But I would like to simply say that her projection of the fund balance, which is $1,897,461.29. She projected that number and was off by only 13,000. So, which is a pretty good projection on the part of Amy Rupi. And then to point out, this is of course the end of the year for us, and to point out what I had previously stated in a previous board meeting, that our fund balance, we have pretty much righted our ship. The fund balance a year ago was 1.9 million. Here it's 1.897 million. Really just a $50,000 drop, which really puts us in very good stead for the next several years. So from a financial perspective. Things that you would not have noticed, but Amy will point out to me and to you, is that even the total fee revenue was also the most fee revenue that had ever been generated by the Department of Health. So bottom line is we're doing okay financially.
Bob,
Yes.
the fee revenue being up, is that from the grants that?
No, this would be a fee revenue from vital records, environmental foods,
see.
et cetera,
All righty.
immunizations. So,
Or on financials, just a couple questions on
Yeah.
financials. On the health COVID vaccinations page, there's $276,000 entry for temporary seasonal help. I think I know what that is, but just for the record, if you could tell us what.
yeah, these are the individuals that we've hired to help with the COVID vaccination clinic who are working as registrars or as vaccinators and working in the COVID clinic downstairs.
And that all hit in December, just that's an accounting thing?
Coming, why did it hit here? I'll defer to Amy. Can you help us, Amy?
The reason there is a lump sum in December, I was waiting for a go-ahead from Dave McCormick with the State Department of Health to be able to take that money that was spent beginning in January 2021 with the Hedwig Clinic to make sure that we were okay in doing that. I actually got the email back, the go-ahead on December 30th to be able to do that. So between myself and the deputy auditor, he of course was grateful that we were willing to take those expenses out of the ARP fund and have them go to this fund. So that is doing everything in from January through December for our temporary seasonal staff.
Great. One other question while you're there, maybe on the health data analytics strategy. page,
Yes.
There's a $70,000 total there. I was just
Mhm.
wondering, is that a transfer or what is?
No, that was a grant
That was a
from
grant, okay.
from an anonymous source.
Okay.
Yeah,
But also I see it going out. I was just curious where it went.
this was what we used to contract with Enfocus and prove the value of having a data analyst working along with primarily the HEAD department. And this will be replaced. This position now of having a data analyst is now within our budget and approved by the council and the commissioners. So,
All right, thank you.
which is what we promised we would try to do when we submitted the grant. So we fulfilled our obligations to the individuals who funded us. They should be pleased. And so we'll ask them for more money at some point for something else.
Good.
Good. Hey, Bob, could you give us an update on what's happening with the medical record? Is there an electronic?
Oh,
medical
yeah,
record
thank you.
coming?
Yeah, and thanks to Marcel Levin as well. So as you may recall, that we were not particularly happy with Azalea for a couple of reasons. And we looked to go to another vendor, Athena, which was really our first choice from the very get-go. Athena is used by Allen County and multiple other physician groups within St. Joseph County. And so we did get the go-ahead to move forward with Athena. That contract is in the process of being reworked, and I expect that to happen really within the next few days. But then it'll be a question of implementing it. And so it's going to take some time to then implement the new electronic health record. But I'm really pleased this electronic health record will also integrate on the back end with the IHI International, the Indiana Health Information Exchange, which should then enable us to be able to access records of St. Joe Hospital, Memorial Hospital, et cetera. Currently, there is a workaround that enables us to do that with great difficulty and a frustratingly difficult process for a lot of our nurses. So the hope is and expectation is that once we have Athena, that problem should go away.
Any other questions? Discussion?
A couple of comments maybe.
Yep.
On the Hope Unit report, I saw in the second paragraph there, a sentence that I thought was very inspiring or deserves more energy in the future. The Director of Hope and he met to work on a comprehensive strategy on addressing the intersections of ACEs, suicide and overdoses. I think that's a real need from, I don't have the exposure you guys have, but from my layman's standpoint, it seems like that's really an important issue that if you can come up with something there, my gosh.
And in the report that Nancy is going to be giving in just a few minutes, she goes over the homicide, overdose, suicide over the last year here, and it's not a pleasant picture, unfortunately.
I don't know if it'll come up in Nancy's report or not, but just for the board to be aware that Health Department's been actively involved in the resettlement of some Afghan refugees. Just thinking about what we do as a health department, bringing people into our community who have very different public health needs than what we are used to taking care of, but being able to rise to that challenge and treat the things that they have that are different than what we have and help them settle in medically and health-wise into our community. It's been nice to see Health Department take a role in that process.
Can I ask a question on that topic? Because actually my husband and I were involved in like the United Religious Communities fundraising to help settle those Afghan refugees. And I was wondering, when people are refugees and they come in, are they given Medicaid automatically? Like, do they have free access to healthcare right away?
Yes, they do.
Well, not quite right away.
Well,
Yeah, not right away. And in fact, the individuals, just to recap, the individuals who are being settled here in St. Joe County and around the country, as I think you all are well aware, were friends of the United States and their lives were at risk. And they are here now, many of them individual men with their families having been left behind in Afghanistan. They come in as what's called this horrendous name. It's called humanitarian parolees, many of them, most of them, in fact. And when they it was through action at the federal level that enabled them as humanitarian parolees then to qualify for the health benefits. But prior to a couple of months ago, they in fact did not have that sort of access. Certain categories of visa holders did, but most of the folks coming in were these humanitarian parolees. We are having so it's a credit, obviously, to individuals within St. Joseph County, led by the URC, United Religious Community, John Pinter, and then Catholic Charities as well, are helping to place 60 refugees, Afghan refugees here in the county. All of them now are getting access to healthcare and health insurance through Medicaid. It can sometimes take a few weeks to get that. But they are getting it, and they will have access to healthcare through Medicaid for a certain amount of time. The expectation is that those who can work will work, and the placement agencies again are finding opportunities for placement in work, and it's being done fairly successfully. It does require a huge effort on the part of multiple volunteers. And again, kudos to those volunteers. And as Jason was saying as well, the help from E. Blair Warner in hosting a screening clinic for the Afghan refugees has been critical to the success. One component of what needs to be done, a very important component, this screening clinic is being done. Janelle Charlton and Kelsey Weidman are running the show, leading that effort, if you will, leading the charge, and doing a terrific job at it.
Anyone else?
And you all as a Board of Health it should also take credit for this, because it is being coordinated through to a degree through the Department of Health and through the Indiana Department of Health and the refugee health leadership in Indianapolis.
Thank you.
Thanks, Bob. Let's move to Deputy Health Officer's report. Dr. Fox.
All right, so the report for the month of December was a lot of time spent preparing for Omicron to arrive. Still no good sequencing data, but we're seeing the highest numbers of infections in the county at any point in the pandemic, about 35% higher than our previous peak, which was November of 2020. And that's in a setting of inadequate access to testing, both PCR testing in the community, the availability of rapid tests through pharmacies and other sites that have been sporadic, and now no availability of rapid testing through the state health department anymore either. So with the highest reported numbers of confirmed infections, we know that we're not capturing all the infections happening in the community. It's had an impact, obviously, on the K through 12 schools, both students and teachers out with confirmed infections, but still all operating in person at this point with masks in place in most of the larger districts, I would say. So there's still some mostly private schools or smaller schools that may be mask optional, but we've had good interaction with the public school districts. The state has been trying to set up a new testing site here that they've not been able to staff. So that was supposed to open the first week in January, and we now don't have a date for the start of that. But in talking with colleagues around the state, we're fortunate that our turnaround time for PCR testing has remained pretty steady at 1 to 2 days, when many of our counterparts are reporting 4, 5, 6 days, where people qualify to be out of isolation by the time they get the result back. So between LabCorp and Connect Diagnostics, a local lab here, ConnectDx, we've actually had really pretty well preserved turnaround time. So
We don't have good availability of treatments in terms of monoclonal antibodies or the new oral medications, a very limited supplies available through the hospitals for that. So that remains an ongoing challenge.
Mark, Jamie, question for you is from the clinician side, and whenever we have flu and it gets to the point where everybody comes in with flu symptoms, has the flu, we stop testing. When are we gonna decide that this is endemic? It's everywhere. I don't know why. I gotta be honest. I don't know why we're testing everybody. I think this push to send out 1 billion test kits, I don't know what that does. If you have fever, cough, sore throat, you likely have COVID at this point. That's where we are. I think it just causes confusion. I think it's a waste of resources. We have many people coming to the emergency room now to get tested because they can't get it anywhere else. The vast majority are going home. So I think it's important that we are messaging to people that Omicrons, we're seeing more and more of, it's people are getting symptoms, even the most, and we're seeing a lot of vaccinated people with Omicron, let's be honest. But I just bang in my head. We see all this test that President Biden's speaking now about all these tests. To what end? I mean, because let's be honest, other viruses like influenza, like, okay, it's endemic, we're done testing now. When you come to the ER, we don't test you. We assume you have the flu. And so I don't know what this does other than make it look like we're trying to do something. So just curious as to your thoughts. I know you're very involved in this as well, but at some point we need to understand it's here. There's an animal reservoir, it's endemic. There's nothing, we just need to learn to live with this and try to do the best we can to be healthy.
Yeah, I think your point's well taken, especially in the face of a shortage or unreliable access to testing. Who should get tested? And I would argue in that setting, it's the people who are at highest risk of severe complications who might benefit from monoclonal antibody or other treatments. So that's where we ought to be prioritizing testing. The federal initiative to provide test kits, it's limited to 4 tests per household, which there are 4 in my household, so it wouldn't go very far necessarily. They won't ship out until late January, when frankly, we should be on the downhill side of the Omicron surge. And so that may be too little too late. And yeah, to your point, if you have symptoms that are consistent with it, then you ought to just self-isolate and wait the 5 days or 10 days, whatever your doctor directs, but at least 5 days. Most people actually would still test positive at day 5. So the guidance is tricky right now. But also to your point in kind of learning to live with it, it has implications for contact tracing as well. The state contract for contact tracing is going to expire in another month or so. And at least what we're hearing is that the state will move away from the call center contact tracing they've been trying to do. They'll send out a text notification, really directing people to a COVID kind of guidance resource center so that if you have questions or need more information, there will be a resource that people will be able to contact, but they won't be doing formal contact tracing interviews and trying to identify close contacts and things, just as we don't with the flu either, right? So we give guidance, go home, go to bed, try to infect as few other people as possible.
One other interesting thing I found out, I was on a meeting with CMS and one of the other hats I wear, and we learned that the tests are free, but there's no budget to pay for Medicare patients. So Medicare patients have no way to get free tests at this time. There's no donut cart that sets a donut hole for them. There's no free testing for Medicare patients, who I would assume would be one of our most vulnerable populations. So if you're Medicaid or if you have commercial insurance, they're free. But even then, the healthcare insurers, Anthem, they have no way to process those claims at this time. Just so you're aware, it's going to be all like paper charts, holding your receipts in a shoebox. But Medicare has no reimbursement strategy and how they're going to pay for the Medicare participants at this time, which I think is a gross oversight if they're going to do this program.
I think, Jamie, I would agree that with what you said about if you have symptoms, you can just assume that you're positive. We see the positivity. I was seeing, the daily positivity data coming out, and a week ago it was maybe 10% were positive, and the latest one from yesterday I think was 25% positive. Well, if people think they have COVID, they probably do have COVID. I think I would like to have those tests to assure that I'm negative before getting together with other people. And I think that that is a good use of having the tests. that if I have no symptoms and I want to get together with other people who also have no symptoms, that we can test for just a little extra reassurance before getting together with them. I think that's a reasonable use
That's
of the
fair.
test, but you're right, to test when you have symptoms, it's going to be positive. You could just save the test. I agree.
And what you say is very true, but that's not at all how they're rolling this out to the general populace. And so
Right.
people are very confused about what to do with these tests. And
Sure.
some people are going to get them just because they like to get mail, like, oh, free tests in the mail. What are they going to do with it? And I just saw they're putting out 400 million K95 masks. They're going to go to CVS, Walgreens and stuff where you can go and get up to 3 masks per person in your household. That's probably a better strategy if we're going to continue with masking than the test kits, because again, people
Mhm.
just don't know what to do with that information.
Sure, but it would be better if people would mask more. That's for sure.
Any other discussion? Thanks. Okay, let's invite Nancy Pemberton to come up and talk to us about public health nursing.
I've been told to make this very brief, and I will make this very brief. Public health nursing. If our public health nurses, we have presently 3, including myself. Want to go to the next slide?
Can you come a little closer to your microphone?
Oh, okay. And right here, we have Lauren, who is basically doing TB, and then she helps out with the regular public health cases. And then there's Lori Montgomery, who is our regular public health nurse, and myself. So what is public health nursing? Public health nursing is the practice of promoting and protecting the health population using knowledge from nursing, social, and public health services. The public health nurses really respond, they listen to the community needs based on the professional knowledge they have and relationship with individuals, families in our community. And the PHN services are 3 central components: the primary healthcare, community development, education, and outreach. Now, with that public health nursing, we're talking about COVID. I can't begin to tell you how many COVID calls we get a day. I myself manage the schools, which includes Mishawaka, and kind of share with Dr. Fox with Penn and the Catholic schools, as well as the South Bend Community Schools, including some of New Prairie, and then over in the Walkerton area, John Glenn schools. So we have a lot of questions coming in all the time. I mean, the phone is ringing constantly, and they are confused about what's going on with COVID, what to do with these kids. And then that doesn't even include the daycares that we get. And I guarantee you, people are reporting everybody. They're reporting doctors' offices, they're reporting surgery waiting rooms, they're reporting anything and everything, nursing homes, everything. They want to go right to the top with this. They just don't quite get it. Then we also had the sites that here in South Bend over on East Colfax that wasn't quite right, and people were not getting their tests results from that place, and some of them had not received their results. Well, they hadn't received it within last week, and they had it tested back in December. So that's all of those things were going on besides. So go on to the next, Jen. The public health nurse's job duties. We do case investigations, case management, TB case management, lead case management, and lead case monitoring. Now, presently, we in the health department, as in the public health nurses, we have approximately 86 community health diseases that we investigate. So our top 3, or I should say our top 5 are is hepatitis C. And that is just ongoing. We have, you want to go to the next one? And then with case management, we have to, get this we have to start immediately on suspicion of anything. We have to report within 24 hours, and some of the others we have to report within 72 hours. Our top 5 cases are hepatitis C, and we've had 208 of these we investigated this year alone. Lyme diseases, 60 investigated, and these were all confirmed. Campylobacter was 60 investigated. They were all confirmed. Strep pneumoniae, 20 investigated. and Salmonella 17 investigated. A lot of the Salmonella and the Campylobacter, we can only investigate so far, but if they refuse to get a stool sample, we can't go anywhere with that. So our TB cases, we've had approximately 10 active TB cases this year, and we've had about 21 latent cases that I should say Lauren has been following. Now, the lead cases, the lead managed cases that we manage actually, which is state required, and it's very specific how they want those cases managed. And that's our blood levels 10 and above. And we presently are managing 38 of those. The monitored cases we have so far with the blood levels of 5 and above, 5 to 9.9. We have a total of 105 of those cases. 60 of those have been confirmed and 45 of those are unconfirmed. And when we talk about those, that the monitored cases take a lot of time because it's trying to follow up with physicians as well as trying to follow up with the families to get those lead testing, round 2 of the lead testing. And that sometimes is very difficult. So on the public health side, what we're seeing now with what we want to do is we want increased involvement in the immunization clinic. We can also do a lot more there. We're going to have I believe this year, we're going to really do a lot of participation with that. We want more increased community involvement, and that helps us with the HEED program, as well as helping out with education in the schools. There's lots to do there. And then we've also, with the help of Harry, involved in the homeless shelter. And we do go out and give immunizations out there, as well as education on Hep C and hepatitis A, which when that starts going up. So our next one, which I know everybody's really excited about this one, the coroner's office. We've got Dr. Patty Jordan, who is our newly elected coroner back in January. We have Dr. Paul Guntert, who is a pulmonologist, Dr. Mike O'Connell, who's in family practice. Then we have a retired chief of South Bend Fire Medics as Randy Magdalinsky, and then we have myself. And there's the pictures of us. So coroner's office, duties of the coroner. We have to by law investigate all homicides, suicides, accidents, anything that's considered undetermined, and natural deaths. So for 2021, our total deaths investigated was 484. That was 34 homicides, 83 accidents, and to date, we have 90 overdose deaths. And 11 of those were still waiting results on the lab. And part of that problem is the labs are so backed up because of staff and everything else. But that'll probably add to the overdoses. And on our overdose deaths, I can guarantee it is mostly heroin, meth, and heroin, meth, and what am I trying to say? Heroin, meth, and fentanyl, right? Sorry. And they are mixing it with anything and everything with the fentanyl. And let me tell you, the suicides are 42 suicides. And 14 have been undetermined. A lot of the undetermined deaths are sometimes infant deaths. And then the natural deaths are 206. Now, why do we have a lot of natural deaths that are 206? What we have been seeing out in the community is the elderly. The elderly population, for some reason, has no family practice doctor, and maybe has not seen a doctor in years. Or a doctor refuses to sign the death certificates. Maybe they have not seen the patient maybe in a little over 2 years. So they will not sign the death certificate. A lot of these natural deaths are homeless. And it's really a problem. And for whatever reason, a lot of the elderly have nothing to do with their families. And nobody has seen them for a week or two. So you can imagine what happens out there after you have a body out there 2 to 3 weeks that has decomped. So back in 2020, as you can see, everything is increased here. Homicides went down a little bit. So we had a total of deaths investigated back in 2020 is 423. And as you can see, the natural deaths went up. And as you can see, the overdose deaths also have gone up. And there I've got it, kind of right there what the increase has been. So I think that we have a lot to do with the overdose and the homeless situation here in St. Joe County. And I don't know what the answer is. I have a different outlook. I probably have more of an outlook as probably maybe as, different than what Dr. Bob says and so forth. And maybe even Harry, I should say. But so anyway, that's kind of it. Anybody have any questions?
Do you work in conjunction with the jail and doing TB testing and stuff when the patients get taken for intake? Do we have any program like that?
Yeah, they do. AIDS ministry. AIDS ministry helps us and they report everything from, at that point. And the nurses over there work well with us on the hepatitis A cases and so forth. Not saying that some of them don't get by, with it, because they do have their rights too, so.
We're probably going to see a little bump in some infectious diseases related to the Afghan refugees in our community. Will there be a way to denote that in the 2022?
Yes, Dr. Bob is working on that right now. And he's on top of it, believe me.
What kind of infectious diseases?
Well, TB and lead, so two that we already are tracking very tightly, but strongyloides, and there's a few other things that are a little more specific to that crowd, but they will look like a blip in many of our statistics for the calendar year. And it'll be nice to have that sort of set aside if we're trending what our basal community rates are now. If all these families stay here in our community, perhaps that will establish a new baseline. But for this calendar year, I think it'll be important for us to set those aside.
Yeah, we're seeing a lot of latent TB relative to our population. And so we're already seeing an increase in the number of latent TB cases. And we're giving Lauren Gunderson, who's responsible for TB, a run for her money. So it's not going to be a dull few months for her. And most of these individuals don't speak a word of English. And sometimes we're working through 3 different languages where you'll talk to the interpreter in English. The interpreter will interpret to a daughter in Dari. The daughter will speak Dari and will then speak to the grandmother in Turkmen. The mother speaks Turkmen, tells it back to the daughter in Dari. You get how it is. It takes a lot of time on the part of our of Lauren to do we're doing a kind of directly observed therapy even for our latent TB, because we recognized right away that there's a lot of confusion and potential for confusion given the multiple different languages.
Mhm. How long is the initial treatment? Is it like 90
For latent
days?
TB, it
For-
depends on the regimen. Generally, they're either 3 or 4 month regimens
Yeah,
now
so it
of
is, of
depending-
everyday witness.
Well, we do have a
pills
weekly
taken.
rifapentine and
Okay.
INH therapy. You can give that weekly.
Okay,
That's taken about 12 pills every Sunday, for example.
all
Yeah.
right.
I had a question about the hepatitis. Is it that that was the number one infectious disease. With hepatitis C, do we usually then see an increase in HIV? And if so, are we seeing that or are you not seeing that?
I'm not seeing that on our end, although I have seen quite a few, and we don't monitor the HIV that's done through the state. But what we are seeing a big increase is, here recently, within the last month to 2 months, is sexually transmitted diseases, STDs.
Okay.
And these people have no insurance. They are having a hard time getting assistance. And the clinics are really backed up in seeing these people. That's what we're seeing. It used to be kind of before the COVID, what I can definitely remember is that if you had a STD, they'd come into the emergency room and get treated with that, and then they'd follow up later. But that's even getting hard for them to do. And most of those people are not going to wait, 10 hours in a waiting room to be seen.
Yeah.
They're just not. And that's one of the things. On the average daily, I get about 3 reports from urgent care, Memorial or some, one of the hospitals of STDs. And I try to, try to get them to the right place, but there's only just 3 or 4 places here in South Bend that actually will handle it. They'll maybe test them, but then they don't give them, the script for it.
Why is that? Like, why are you getting reports on sexually transmitted infections rather
Because
than?
number one, that is reportable to the state.
No, I guess, let
Right,
me
and there is a
rephrase that.
number.
If I test a patient
Mhm.
for an STI and it comes back positive,
Mhm.
yes, it's getting reported to you, but I treat the patient and her partners.
Mhm.
I'm not expecting you to do that. Why
Right,
is
but-
everybody not doing that?
Well, again, these people are street people, that maybe, have, the condition starts arising and they can't take it anymore. They're not
Okay.
people that come in, like
Okay.
you're going to be seen.
Okay.
Or
alright.
normally they would have gone straight to the ER and been seen by that. Am I not
Okay.
correct on that?
So you serve as basically a referral base, like people come to you
Mhm.
looking for help and you're trying to connect them with
Yeah, and usually what we
services in
do
the
is
community.
Indiana Wellness Center, through IUSB Wellness Center, they will accept them by appointment only, but they're getting pretty, and then Indiana Health Center will vet them, and the Olive Street Clinic will, and then sometimes we send them over to the AIDS Ministry and that route, And sometimes the Southeast Clinic, but, their resources are limited too,
Aren't you able to give prescriptions as the public Department of Health officer for prescriptions for STIs? I thought there was law for that.
We don't treat that. We don't have an STI clinic that disappeared sometime before I came on board here.
But if cases come to you and they're positive with no doctor, you should be able to write them for Zithromax. So that should fall under your purview.
If I had a clinic and the capacity to run a clinic, we could do that, but we don't do that currently. So.
Do you know what percentage of counties in the state of Indiana have STI clinics as part of their health department?
I do not know. I've actually seen that number, but I don't know. Do you
No, I
have
don't know.
any
I
idea?
know that Elkhart County does, have, they have a clinic going. I believe, let's see, I've been actually with the St. Joe County Health Department approximately, I think about 6 years now, and I think that we lost our grant in that.
Yeah,
at
the
that
grant,
time.
I think what happened, Jamie, and correct me if I'm wrong, for those of you who are here, but the individual nurses who were actually running it for the health department competed against the health department for the grant, for the state supported grant. And I think the health department, in fact, maybe didn't even put in a application. And so that's how the Olive Street clinic got formed. At least that's how it's been explained to me.
Yeah.
Is
that's
that-
kinda how
yeah.
it was explained, yeah.
So, and this was several years ago.
Mhm.
Yeah.
I came on board 6 years ago and it was already gone before that.
Mhm.
Yeah.
So it's been some time that we lost it.
Mhm.
I always felt like it's an essential function of public health to be
Yeah.
able to offer those kinds of services. And I know that, Bob, we've had just like some, conversation about, is that something that we should be looking at and, resurrecting and providing that service. So maybe it's something we need to look at later. Nancy, if I could ask you another question, just one other. I know, childhood lead testing is down and immunizations are down. Is your nursing department talking about how we're going to increase lead testing for kids and immunizations? Any
Well,
plans?
We're working with Cassie. That's going to be part of their community health workers, and she's in the process of getting that together. We've been having meetings in regards to that, but there's no reason why their community health workers could not take on that role and go out there in the community and, get those kids with the lead paper and so forth.
Well, they are.
They
taking it
are
on. It's
at
not like
some
this
point
just been
now, yeah.
meetings. They've been doing it.
But what we're seeing with that even, again, is some of those do have doctors. And we've ran into, the physician, when it got back to the nurse, the physician didn't even know they were retesting when they were going to be retested in another month with the venous. So there's been some confusion, and we're trying to get all of that kind of ironed out a little bit, and that's what Cassie and I are working on, or will be, actually, Jody will be working on.
And then to
get
get
that.
reimbursed, Heidi, I'm not sure if you're aware of this, but some
Yeah.
of the insurance companies are requiring that we get pre-authorization before we do the lead tests. Otherwise, the insurance companies won't reimburse. I mean, this is like $2.50. You're asking for pre-authorization, going through the rigmarole of trying to get pre-authorization. And so if you go to a daycare center and want to do the testing on the kids, it's a matter of trying to get all the information ahead of time, get the pre-authorization, et cetera, for selected insurance companies. So there's various complexities to this.
And that information will be available once the Athena EMR is up. That'll be accessible so that, no?
Again, unless the individuals have already been registered in, but if you're going to go to a daycare, de novo, if you will, it's going to be a question of getting all those kids registered. Whereas, what you'd really like to do is just go to the daycare and start doing the testing right there on the spot, rather than having to contact an insurance company a week before you go out, getting all their kids' information, communicating it to the insurance company saying, yes, you can go ahead and do that test and we'll pay for it.
Well, I mean, that's just
But the
ludicrous.
information-
It is. It's absurd that we would
Yeah,
have to
I-
get pre-qualified for pre-approval.
I don't understand.
I don't know if
it.
the board is aware that there are two bills right now going through the State House. One is related to water testing for daycares and schools. And the other one is to mandate lead testing to come into compliance with CDC. The one thing that I was not clear on is, and maybe somebody else knows the detail of that bill, we knew it was for kids that are under 6 years old. What we didn't know, is it for all kids under 6 years old, or is it for Medicaid children who are under 6 years old? So, but the good news is it seems to have traction and support. So
Good.
hopefully we will move in that direction, and then we won't have to be traveling out to go get.
But I do
kids
guarantee you, when they
tested.
do come into the clinic and we have them there, we ask them, about a lead test. Would they, let their child? Some say absolutely not. And, but the majority of them do get lead tested when they come into the clinic,
Do you keep track of the refusal rate? Just
We
kind of
haven't been
curious.
keeping track, no.
Hmm, okay.
Unless there's any way, Cassie, have you been, there's no way that you can. is there? No.
Interesting. One other thing, Bob, I know that in our last meeting, I believe you've had some new hires in the nursing department. I just wanted to
Yeah, thanks.
acknowledge.
Yeah, in fact, I'd like to introduce Jody Parrots to you. There, Jody, as our new Director of Nursing.
Welcome.
I think
So
we're gonna
Jody
see great
comes
things.
to us after fairly several decades working in the memorial labor and delivery. And as well, she worked with us, pursued her master's, and as part of her master's, she interned, did her practicum under Nancy's guidance and direction.
Awesome. Welcome.
Wonderful.
To a question that you asked earlier, John, the health department does have a role in our county suicide and overdose fatality review board, which actually our county's version of that has been held up for a model of other counties and how that can look. It includes health department and coroner's office and probation and law enforcement and the jail and physicians and mental health, and review those cases of accidental overdose and suicide. There's some overlap there too. And with the purpose of asking the question, what could this community have done differently so that this didn't happen? And we do that in the presence of the State Department of Health, who takes notes on that and thinks about how they will prioritize some financial things for the state based on, how we are reviewing those cases. So it's been a very exciting and robust conversation to hear that happen. We've had actually observers from other communities and states who've observed our meetings as a model for how that can happen in other places. So again, kudos to, a group that includes the health department for doing that kind of work.
Wow, that's great. I had no idea. A couple of years, maybe? Yeah.
Awesome. Oh, where'd Nancy go? Thank you, Nancy, for your presentation. Appreciate it.
Thank you.
Thank you. So before we go into old business, I needed to mention that with the upcoming public comment, if you would like to speak, we have a clipboard right there here in the room. And then, of course, if you are online, please sign up in the chat with your name and city where you live, and then we'll call you in the order in which it appears in the chat. Okay, moving on to old business. We need to talk about nominating committee recommendations. And so, as you know, we have a Finance, Personnel, and Appeals Committee. And right now on the Finance Committee, we have myself, Dr. Marker, Dr. Shoemaker, Dr. Migliori, John Lynn. On the Personnel Committee, we have me, Dr. Kirsch, Dr. Marker, and the Appeals Committee is Dr. Marker and myself. I would entertain any changes that anybody would like to make, move around. How does that sound? Would you rather be someplace else?
I would move that we continue with those same committee assignments for the coming year.
Second.
Any discussion? Not hearing a discussion, we'll go ahead and take that vote. So in favor of keeping the health roster as the committee roster as it is, all those in favor?
Aye.
Those opposed, the ayes have it. We will keep our roster as is. Okay, and then for board notifications, there are none.
Madam President?
Yes.
I was going to sneak it in and try to under old business, but at the last meeting, there was an allegation that maybe our board was not put together properly. And if it's inappropriate, just say so, but I think it would be good to let the public know, that that's been handled.
Yeah, thanks, John, for bringing that up. Yeah, so there was an allegation that things have been improper. We actually found out that we were not out of compliance because I believe it was associated with political affiliation, and we were not out of compliance. We had to do some digging to find some information about voting patterns and so forth, but we were not out of compliance. What we did learn, and I want our board attorney to correct me if I'm wrong, because I want to make sure I get it right, is that in 2017, there was an amendment to the state statute that gives the county executive the sole responsibility for doing appointments to the Board of Health. So Emily Dean is no longer on our board. And so the county executive has asked this board to put together a list of 5 possible candidates that they have asked for and are going to review. I'm sure that they'll have some of their own candidates as well, but we will go ahead and collect that among our group, our board here, and then we'll submit those.
When you say the county executive, who is the commissioners?
Commissioners, right? The 3 commissioners. They have that responsibility, and there has to be a political balance, just like there was before. You cannot have more than 4 of any party on the board. So that remains the same, but the appointments are different. So Mayor Wood and Mayor Mueller will no longer be able to appoint people to the board.
And if I could ask, how is an independent defined to serve on the board?
I'm going to turn that one over to the board attorney.
The statute says that if you have never voted in a primary, if you have never voted in a primary, then you can go to the county chair for either party and get certified as a member of that party. And if you're not willing to do that, then there are some other things that can be done.
But since there is no independent primary, and most people from age 18 have voted at least once, how does an independent get to join or at least be considered for the Board of Health?
Hey, Marcel,
They talk to their state legislator. If you voted in a primary, you are whatever you voted in the last primary.
and it's the last, correct me if I'm wrong, but I read the statute again today. It's the last primary that you voted in prior to your appointment date. So that's even different. So an independent would suggest that you're voting Republican and Democrat, depending on the year and who you're voting for. But when you got appointed to this board, whatever primary, however you voted in the primary directly before, that's how you're getting categorized. Yep. So in fact, when we looked at all of that, we were not out of compliance with regard to political affiliation. But then what we did learn is that the county executive has the sole responsibility for appointing the board. So that's quite a change.
Thank you for clearing that up.
And I'm just curious, has anyone looked at the other counties around the state to see how many counties comply with this statute?
No.
Are you on a listserv with perhaps with the other county health department attorneys where a question such as that could be asked?
I don't think there is one.
Interesting.
Maybe there's some grad student at Notre Dame who wants to have a summer, a law student, right? Exactly. Okay, anyway, setting that aside, let's go to public comment. Jenny, do we have anybody signed up? Oh, I'm supposed to read the preamble. Okay, and do we have any on the clipboard? No. All right, awesome. We have no public comments tonight. So our next meeting is on February 16th, right here in this room at 4:30. And we are adjourned. Thanks, everybody.
I'm trying to see the.
Blocking it, sorry.
Ellen Stecker, family physician Ellen Stecker just asked whether or not the health department pays for needed vaccines for refugees, including hepatitis A. And
Oh, since they eventually get Medicaid, we don't, what we've been doing is haven't been giving them immunizations until they get